and welcome to They Say It Takes a Village. My name is Raya. I've got 2 little boys, a full-time job, and now I'm adding amateur podcaster to the mix. So it's safe to say that it really does take a village, at least for me to raise my kids. This podcast is aimed to give moms a fun, unfiltered, and an informative outlet to navigate all things motherhood. Join me each week as I interview one of our local heroes from my village who make mom life just that bit easier. Think of me as your personal mom group, bringing you recommendations when you need it the most. Having said all that, let's get into today's show. They say however parenthood comes to you, it's a miracle. Hi everyone, and thank you for joining me on another episode of They Say It Takes a Village. Today, I'm so delighted to be joined by Dr. Diana Kayal as we discuss the expansive topic of fertility, particularly fertility assessment and treatment. Just to give you a little bit of a background on Dr. Diana, she is the medical director here at Bourn Clinic, Dubai. She's also a specialist in the area of reproductive endocrinology and infertility, and has been practicing for over 35 years. Dr. Diana, thank you and welcome to They Say It Takes a Village.
Thank you for having me in your village.
Oh, it's such a pleasure. It's such a pleasure for you to be here and taking the time out. I know you have a massively busy schedule.
Most welcome. All the pleasure is mine.
Just even though I've given a little bit of a background, do you want to tell the listeners just a small bit about yourself and how long you've been in the UAE?
Oh, about me. I'm a born expat. I'm Lebanese national. I was born in Lebanon. I grew up in Tunisia. I did my studies in Belgium and I graduated in 1997, and then I hit the Middle East. I've worked in many countries like Saudi, Bahrain, and I've been in the UAE since 2012, where I started up the Bourn Fertility Clinic with one of my previous colleagues.
Fantastic.
Thank you.
That's so good. So we've been here for a long time.
Very long time.
Long time. So we've seen it from very early days until the wonderful city that it is now.
Absolutely.
Yeah. I guess just to jump straight into the episode, of course, this one is, I feel it's such a fully loaded topic, fertility.
Absolutely.
And I feel today we're just kind of scratching the surface a little. So a part 2 is definitely needed.
Oh.
But just, obviously the term fertility gets thrown around a lot. But what does it actually mean? At least from your point of view, from a medical point of view.
So let's start by defining fertility.
Yeah.
What is fertility? Fertility is the ability to conceive, to get pregnant, and to deliver a baby. And then we go to infertility or subfertility, which is the inability to conceive. And then we can have primary infertility or secondary infertility. Primary infertility is the inability to conceive after 1 year of regular unprotected intercourse. Secondary infertility is the inability to conceive after 1 year of regular unprotected intercourse, but to the previous history of a pregnancy, whether it's a childbirth or an ectopic pregnancy. So you've been pregnant once, you had a baby, let's say, and then you can't conceive again.
Yeah.
These things can happen. So you define it as primary or secondary infertility.
So it's not just, there are different facets of fertility. It's not necessarily just one big word.
No,
or term.
And it's very common. It's more common than people think. Usually around the world, we say it affects about 1 in 6 couples. But unfortunately, it is more common in the Gulf region or the Arabian region, affecting probably 1 in 7 couples.
Is there any reason behind that?
Well, I would say lifestyle, obesity, polycystic ovaries, so that affects a lot fertility.
Okay. And so generally, that's the fertility term from a medical point of view as well. I think another big thing, of course, now as women, now women are career driven and they want to travel a little bit more. They want to live their life. And I guess we move a little bit from the paradigm of getting married a bit younger and having kids, sort of fairly close to a younger age. I think a main concern for a lot of women is the age factor.
Absolutely.
Why is a woman's age or the fertility of a woman so finite?
The thing that women need to understand is that we are born with a certain number of eggs in our ovaries. We do not make new eggs. Okay, so we are born with a certain number of eggs in our ovaries, and with age, we lose our eggs. Not only we lose our eggs, but the quality of the eggs deteriorates, which will mean that we will generate less pregnancies. We do advise women in general to have at least one child at the age of 35 or below, because that is your peak of fertility between 25 and 35. Fertility starts declining in the early 30s and late 30s, but then a woman will lose all her fertility between the age of 40 and 45. We cannot create new eggs. Some women think that because I'm taking the pill, I'm not ovulating.
You're still
I'm still preserving my eggs. No, that's not true, because we actually start losing our eggs even before we're born.
Oh,
Even before you
wow.
get your menarche, you start menstruating, you're losing your eggs. You lose huge quantity every single month of your life. And that's why we head to menopause, is when we don't have any eggs anymore. And until now, we haven't been able to find anything scientific to regenerate eggs or make new eggs.
Wow. And so basically, so you're saying 35 is quite a turning point for a woman.
35 is a turning
35.
point, because
Okay.
only 50% of the women will get pregnant at the age of 35 after 1 year of trying.
50%.
Only women think that it is, like 80%. No, it is like 85% of the women will get pregnant after 1 year of trying when they are 25 years old.
Wow.
At the age of 35, it's 50, and the age of 40, it's 35. But that's after 1 year, because you count. The more you try, the more chances you have to get pregnant.
For sure. And so obviously that's that could potentially be, so the factor or the age factor can be a contributing, a contributing issue to fertility when it comes to
It's a major
female side.
issue.
Yeah. So what about in the reverse? So what are some potential fertility, I would say, blockage, or I don't know, sort of issues that men face?
Well, fertility issues for men is basically the sperm.
Yeah.
Correct. So if you have any history, for example, of infection in the sperm, or any infections like mumps could affect the sperm, or if you have a history of surgery like undescended testes or inguinal hernias in men. So the sperm is very important in conception, and luckily the men have the testes, and luckily for them, they have the testes, and the testes is a factory.
Wow.
So they are not born with an defined number of sperm. They produce sperm all the time. And the sperm is
their entire
regenerated
lives.
every 90 days. They
Wow.
produce a new batch of sperm. So they're very lucky, aren't they?
Yeah. So it just doesn't end until
It's
for the
always
whole
on the
month.
woman,
My
isn't it?
goodness. And I mean, so is it that, just to sort of understand, so okay, so the potential issues with men always has got to do with a potential issue with the sperm.
Yeah.
Okay.
Mostly for that. No, sometimes it's genetic conditions.
Okay.
Sometimes it is diabetes. Sometimes obesity can affect fertility. So there are many issues, but I'm focusing essentially on the sperm, as we're talking about the eggs earlier.
Yeah. Okay.
So it takes an egg and a sperm to meet to create an embryo,
yeah.
and then later on a fetus and a baby.
Yeah. So you touched a little bit on that right now in terms of lifestyle factors. Are there, aside from, let's say, not conceiving, are there any other lifestyle factors or any other signs that may indicate there is a underlying fertility issue?
Definitely. For example, for women, it would be irregular cycles. Some women have hair on their face or on their body. It's called hirsutism, or milk coming out of their breast. So there are some clinical signs that would draw attention to fertility and saying, I might have a problem, and then they should seek, the attention of a doctor and try to investigate. In men, it could be problems with erections, with ejaculations, the decreased libido, or hormonal, anything that is can draw your attention to signs that are clinical but related to fertility or sexual health, actually, also.
And do you think that that's a good time for them to actually seek professional sort of to consult with a doctor?
You don't necessarily need to have symptoms to seek. If you are a woman of 35 years old and you want to know what is your fertility potential, you can go have a fertility check.
At any point?
At any point. I mean, if you're not going to do your fertility check if you're 25, you know what I mean? But I mean, let's say you're in your 30s and you know what is, you're fine and you're okay, but you don't want currently to conceive, you can go check and find out if you have any issues with your, let's say, egg count, even though your cycles are normal and you don't have any symptoms, just because you want to delay conception. If men have any symptoms also, like erectile dysfunction, or if they are diabetic and they need to check their sperm, there's nothing wrong in checking.
For sure. Yeah, just to put your mind at ease.
But without putting the pressure on yourself and saying, putting in your mind, oh, I have a problem, I can't conceive.
Yeah.
So I think it's a double-edged sword.
I was going to say double-edged sword. Yeah. So I think that sort of leads to my other question. When it comes to fertility assessment, let's say you've got a couple, they're not potentially planning to have any children within the next year or two. Would you recommend them regardless to come in proactively and just to get an assessment in case, or after they've tried for the X amount of time that they need to?
If they want to do a fertility assessment, that is definitely doable. We can do a hormonal profile on the woman, check the ovarian function, the thyroid function, the milk hormone. And also what is very important and talked about a lot currently is the ovarian reserve. We measure a hormone called the anti-Mullerian hormone. Now, the anti-Mullerian hormone gives us an idea about the egg reserve, the potential of fertility. So if I compare the ovary to a bank and the eggs to the money in the bank, the AMH will give me the credit, an idea about how rich or how poor I am in the number of eggs I have in my ovaries. Some people are rich, some people are poor, and some people are average.
I see.
So maybe you have a very good ovarian reserve, maybe you have a low ovarian reserve, and then you don't want kids at 35, and maybe it's a better option to freeze your eggs then, or freeze your embryos if you're married.
Okay.
We can also check the fallopian tube for women to make sure that the fallopian tubes are the pipes that make the sperm, where the sperm travels to meet the egg and fertilize it. But obviously, before doing any fallopian tube testing, you need to make sure that the sperm is good in quantity and in quality.
So when you do an assessment, would you do it together?
Yeah.
Okay. So both the
male and female.
Yeah.
And everything is done too.
The woman
of course. On her own can't do much, and he on his own can't do much either.
Of course.
So fertility is an issue for a couple.
Yeah. I think there is a lot of anxiety around it. And I think, a lot of the times you speak to couples, if they're not really ready to have children, but it's always in the back of their mind, can I have children? And as the years roll on, they probably, get closer to the time of wanting to start kids. And I remember even from my own personal point of view, I wasn't sure whether to get checked everything before we started, sort of thinking about babies, or just, like you said, to try for a baby and then come in if we run into
most of the people would just, especially if they're young, especially if you're below the age of 35, you can go ahead and try for a year before you seek any help. Okay? If you are above the age of 35, you do not wait more than 6 months, because the age factor, again, is very important. So if you're below 35, you can allow yourself a year. If you're above 35, it's 6 months only, but you do not wait at all. If you know that you have a certain condition, let's say you know that you have polycystic ovaries, or your cycles are irregular, or you're not ovulating, or you have had a previous history of pelvic inflammatory disease that blocked your tube, so then you don't wait, you seek proactively the help of reproductive endocrinologist or fertility subspecialist.
So it's case by case almost.
Always case by case.
Yeah.
Individualization of treatments and assessments.
I think you just mentioned just about a couple who's trying to conceive, and there's sort of almost like a rule of thumb: under the age of 35, wait a year. Over the age of, what was it, 45?
No, 45, forget it. 35 is the mark.
Okay.
Below 35, above 35.
Okay. And if you're below 35, you can
1 year.
1 year before any intervention. Okay. Above 6 months.
Only 6 months.
Got it. And now, of course...
Unless you know that there is a problem, then you don't wait. There's no point in waiting.
Yes,
right?
That's right. Just go in, get it sorted, put your mind at ease, and just get the help. There's so many, wonderful people such as yourself ready to help.
For example, if you know that in your family, like a woman knows that her mom had an early menopause, or her aunt's mother side had early menopause.
Gosh, I didn't even think of that. Yeah.
She should seek fertility testing to make sure that what is her egg reserve, and potentially, if she's a single woman, freeze her eggs for future use, rather than waiting until the egg count is very, very low, and then you can't achieve, because you freeze your egg to achieve a successful pregnancy later in life.
That's right.
So if you have history of early menopause in the family, it's a good idea to see a fertility specialist.
Got it. Perfect. That's some good advice. I never would have thought that, to look at the family history in terms of age of menopause. Good tip. And of course, just again, I think taking the first step to see a fertility specialist is a little bit anxiety driven.
Always.
And I think I'm pretty sure you get lots of couples sitting in your office a bit on edge, and it's a very sensitive environment.
Very.
And so to ease everybody's mind, what can, for example, a woman expect on an initial fertility assessment? What would you naturally do right at the start?
We will take history from about the periods, when did she start menstruating, how her cycles are, sexual history, sexual advice on how, regular unprotected intercourse. We also talk about lubricants, because lubricants kill the sperm. You need to use, the commercial ones, regular ones that you buy in the supermarket are not sperm friendly. Yeah. And there are some lubricants that are sperm friendly. We take a history from the husband. We also talk about, the smoking, the drinking, anything. Yeah. And then we discuss our options. And it's, as I said before, case by case, and it depends on what they are coming to see us for. If they've been trying for a long time, then we would probably direct them directly to a more aggressive fertility treatment. But usually we start step by step and escalate the treatments.
Is there almost like a set protocol of, for example, a panel of blood tests that you would do, or anything like that you would include? We
always do a hormonal profile to assess, as I said before, the ovarian function, thyroid, etc. Yeah. We check that the woman is immune for German measles, because German measles has a vaccine. And if you are not vaccinated for German measles, we advise that to have a dose of MMR vaccine. Because if you get it during the pregnancy, there is a risk of malformation. Yeah. So that's why we need to get women vaccinated for German measles. Yeah. We make sure that they're taking their folic acid, because taking the folic acid is actually not for the woman, it's for her fetus, the baby to come, because it reduces the risk of what we call the neural tube defects, the babies that are born with opening in the spine or the head, by 50%, which is quite drastic.
That's a lot. Yeah.
So starting folic acid 3 months before conception and continuing it for the first 3 months of pregnancy.
That's fantastic. And of course, for our better half, the males, the men that come with us, what's involved in initial assessment with those guys?
The semen assessment to check that the sperm quantity or quality are appropriate. Sometimes we do more testing, but it's, again, if we need to. Sometimes we need to do karyotyping, chromosomal analysis, meaning a woman is 46XX chromosome count, the man is 46XY. Sometimes we need to do these things. Okay. Sometimes we need to do a laparoscopy, a keyhole surgery. This is rarely done now, because mostly with the ultrasound, we can assess most of the things and know what's going on.
So would you, let's say, again, the couple that has come to see you and have done a few tests and sort of to get almost like a profile of what's going on, are there anything that they can do just as a lifestyle thing, sort of to increase their chances, whether that is to, I don't know, is it, it's egg quality or sperm quality or anything to increase their chances before, during, or after treatment?
Throughout, it would be my advice to tell them to lower the stress levels.
Oh, so that was another huge question. Stress, and how does that affect?
It is really a big impact on the psychology of the couple. I mean, fertility is a major issue. The inability to conceive hits both man and woman. And the woman cannot do it alone, the man cannot do it alone. So they need to be supportive to each other. I always advise to find an activity like you like doing, cooking, knitting, walking, Ayurveda, acupuncture.
Yoga,
So anything that would take the stress out of your mind and the constant thought of I want to get pregnant and I'm not getting pregnant and why am I not getting pregnant? Remove the culture of blame. It's not your fault. It's not my fault. It's nobody's fault. And we're working on it and hopefully we'll achieve something. Don't smoke.
Okay.
0 cigarettes, please. Very bad smoking, especially for women. Drinking, not good. I'm not going to say do not drink at all, but you can have 2 to 3 drinks.
Limited.
Very limited alcohol intake. Definitely not binge drinking. people think that you don't drink during the week. That's
and then
fine.
You go crazy.
And then you go crazy over the weekend. That is a very bad idea. Saunas for men, the testes are outside. We women have our ovaries in our pelvis. They're protected inside, but men, it's outside. So trauma on the testes, saunas, hot bath, cycling for long hours. You see, because it's the trauma on the...
Good to know. So don't join the Tour de France then. Not while you're trying to have a baby.
Well, exactly. So just, these little bits of pieces, and obviously take your vitamins, exercise, and it all sums up to one word, lead a healthy, moderate lifestyle. Everything in moderation is okay.
Yeah. Just obviously on the stress, it's so easy, the stress and the blame. I have to go back to it because it's so difficult to pull stress out of a situation like this.
It is.
And you're right in the sense that it's probably, it's good to get into an activity because you can't help but think, I need to have a baby. I want to have a baby. And it's, I think from both a man and a woman's point of view. So, do you see that obviously the more stressed a couple is, the less likely they are to conceive? I mean, is there a direct connection?
I don't think that I can say a real direct connection, but you can definitely see a link there. I mean, a stressed woman can have a higher cortisol level and block her own ovulation.
Yeah.
But it has a big, big impact on the way it's done, the journey of fertility treatment. By being stressed, you make your journey so difficult. I mean, it's an emotional period of your life, especially when you start the treatment. The emotions and the expectations are so high.
Yeah. So obviously,
talk to people. Talk to your friends. Talk to somebody you trust. It used to be a taboo to talk about fertility. It's not anymore. So there is no shame in, having psychological support or a life coach or a support group, or just a friend.
Yeah, I think that's really important, to have people to listen to you, like a support group, for you to voice your fears and anxieties and your stress, and to have somebody a little bit more unbiased to discuss things with you and sort of reduce it.
Don't be influenced too much also by what people tell you, because if I have a negative experience and I'm in a support group, I might be also spreading negativity around. So you have to balance your choices and be select. And please stay away from Google.
Oh gosh. Dr. Google, just do not go on it. Do not go on it.
It's important
do you
to
get
read
patience?
and be informed, but please do not let it get into your head
Yeah.
too much. That will just only raise your stress
I
levels.
can imagine. I'm sure you
Yeah.
get patients coming, but Google told me that this, and that.
Oh yeah.
Why did I waste my time getting all these degrees then?
Absolutely.
Just to jump straight into the technicality of fertility treatment. What are of course, we all know fertility, and I guess the big one is, of course, IVF. But there are other more conservative options.
Sure.
What are they? I mean, what can people expect in terms of the umbrella of a fertility treatment? What are conservative options?
The fertility treatment is actually very simple.
Okay.
It's either ovulation induction, where we give women some tablets or low doses of injections.
Mm-hmm.
We monitor the growth of a follicle.
Mm-hmm.
We give an injection to make the patient ovulate, release her egg, and then she can have timed intercourse. Okay, this is just to make sure that an egg is being released somehow. Okay, then you can move to intrauterine insemination, which is also, all techniques will involve some kind of ovarian stimulation drugs.
Okay.
We give them drugs, injections, monitor the growth of the eggs, and there also we want 1 or 2 eggs only.
Yep.
And then we trigger ovulation, and then 36 to 40 hours later, the couple, they come together. The man gives us a sample of sperm that is washed and prepared in the lab, and then the sperm is put inside the uterus.
Okay.
These are very simple techniques that do not have a high success rate because we're actually not doing much.
Okay.
Correct?
Yeah, you're just kind
So
of
exactly,
putting them together in the hopes.
The sperm, the guy ejaculating in a vagina, I'm putting the sperm inside the uterus, but the sperm is prepped, cleaned up, and it's put inside the uterus at a time where we know that there's ovulation happening.
Got it. Okay.
So these
so
are
that can
the
be
simple.
that's a conservative.
That
treatment.
is the only thing you can do as conservative, right?
Okay.
But these treatments are not suitable for everybody. If you are 38 years old and you've been trying for, let's say, 6 months or a year, would I recommend an intrauterine insemination? I don't think so, because I don't want to waste a month, 2, and then 3, and then time's of essence. The older we are, the faster we should get into more aggressive fertility treatments.
And so the more, I would say, not aggressive, but the other arm of fertility treatment
is IVF. That's it.
And what is, I mean, again, you hear the word, I mean, even me, I'm constantly hearing IVF, but what does that, I think it's multiple procedures, I would say.
Well, the only difference I would say is that the doses of medication that we use are much higher, because we don't want 1 egg or 2 eggs. We want 15 eggs, actually 20 eggs, if we can get to retrieve. So we give injections, we monitor the growth of the eggs with ultrasounds and with blood tests. We trigger ovulation, and then 36 hours after the last shot, the trigger shot, we collect the eggs through the vagina under a light general anesthesia.
Okay.
So the eggs are taken out of the body. Okay. That day we need the sperm.
So you get a sperm sample?
We get the sperm sample. The husband provides us with a sperm sample. And then the sperm is and then we do either conventional IVF, which is just letting the egg and the sperm in a dish, let's say, and the sperm is swimming and fertilizing the egg on its own.
Okay.
Or what you can do is the intracytoplasmic sperm injection, where each egg is injected with the sperm. So literally the sperm is put inside the egg.
Wow. Okay.
And then the sperm fertilizes the egg. The fertilized egg divides and become an embryo. And we try our best to transfer embryos when they are 5 days old. That's called blastocyst. Strongly recommend to transfer only 1. Sometimes we do transfer 2, but definitely not more than 2 embryos are to go back to the uterus.
Okay.
If we have remaining embryos, then they go to the freezer for future use.
And with these embryos, this is a bit of a side question. Do they undergo testing and all sorts of screening? No.
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 That the
Okay.
simple IVF cycle is stimulating the ovaries, collecting the egg, fertilizing the egg, and transferring embryos.
Okay.
If we get into the side of we're screening the embryos, that is taking biopsies on the embryos, cells out of the embryos to be analyzed, and then the embryos are frozen and transferred in a subsequent cycle.
Okay. So let's say from start to finish of an IVF treatment.
19 days.
Wow, that's actually quite quick. I didn't
So
think
if
that.
we have done the preparation before, we've seen the patient, we've done the blood test, we've done the semen analysis, day 2, day 3 of the period, the patient is seen. She actually calls the clinic on day 1. She's seen on day 2 or day 3. We have 10 to 12 days average injections during...
Prior to this.
No, this we have
Oh,
started the process.
Got it,
We start
okay.
with the period, okay?
Yeah.
Say day 2 of the period we started. I have 10 to 12 days injections. The patient will self-inject. We will teach her how to inject herself. We will see her at the clinic 4 times.
Sorry to
Always an
interrupt you.
average. Yeah, go ahead.
The injections that they're injecting, what are they?
They are hormones
To stimulate.
to make the ovaries that are on the eggs that are on the ovaries grow.
Perfect.
Okay?
Yeah.
So we monitor the growth of the eggs. Average, we need 4 visits. At the last visit, we give the injection to release the eggs. 36 hours later, the egg collection. So 10 to 12 days. 2 days, that's already 14. Plus culturing the embryos until they're 5 days old, that's 19 days.
And so day 19, day 20, you're ready for?
So 5 days after the egg collection, we transfer
the embryos. And then obviously to extrapolate.
10 days.
Yeah.
So 2 weeks after the egg collection,
Yeah.
we do the pregnancy test, and then either we're pregnant or we're not pregnant.
Okay. Gosh, it's unbelievable.
It is.
It really is
actually.
unbelievable, isn't it? It's just
Yeah.
for a small, a procedure to be almost less than a month. It's amazing. It's amazing. I love the fact that you've got the 2 options of either to leave the egg and the sperm to meet, or the one when you sort of
It has
inject
their own indication. Each technique has its indication.
Okay.
And that's the lab usually that decides what
They do
have
their
to
own,
do.
yeah.
That's their job.
Their
I
job.
just give them the egg and the sperm and they deal with it.
I love it. Absolutely. You mentioned IUI, as of course that's something that is unlike IVF, being that it's a bit more conservative and you're not really removing any of the eggs or anything like that. You're just sort of injecting the sperm into the uterus. So you're basically bypassing.
It's releasing the sperm with a small catheter inside the uterus.
Yeah. Do you find a lot of the times, I think when you think of sort of any type of assisted procedures for fertility, I get maybe not so much a fear, maybe some people it's desired, but a common idea is that you might be pregnant with multiples. Is there any procedure, whether it's IVF or IUI or any other thing, that is more likely to to result in a multiple pregnancy?
Definitely.
Okay.
Inseminations.
Okay.
So if let's say I have 3 follicles, it means 3 potential eggs, and I go in and I release the sperm inside the uterus. It's going to travel, and then either we're not pregnant or we're pregnant with 1 or 2 or 3.
Okay.
So intrauterine inseminations have low success rates and high risk of multiple pregnancies because people tend not to cancel cycles. Not to say to the woman, I'm not doing the insemination. But sometimes even if I say I'm not doing it, they go home and have intercourse.
That's right.
Right? So the eggs are there, and then they can say, who cares what Diana said?
Yeah.
I'm just going to go for it. Yeah. And here you go, you have triplets, right? In IVF, we know what we are transferring. And that's why I said, let's transfer 1, maximum 2. So if you transfer 1, either you're not pregnant or pregnant with 1. If you transfer 2, either you're not pregnant or you're pregnant with 1 or 2. Yeah. Very rarely, one of the embryos that we transfer can split and becomes 2. But that's a very rare condition, very rare situation.
Yeah, because you kind of link it together. Fertility treatment and multiple pregnancies.
Absolutely. If you see the number of multiple pregnancies we have around is huge, and it's all due to fertility treatment.
Yeah.
And actually, it's some kind of fashion for the moment. I have people that are absolutely fertile. They have no problems at all. They come and see me and they say, I want twins.
Do you know, it's that as
And
well, or
this
the
is-
gender selection?
No,
as
gender
well.
selection is something else.
Okay.
But wanting twins, I mean, I am totally against multiple pregnancies. Not because they're not cute, but if you can imagine how you are a mother, so you
Yeah.
understand how
Yeah.
difficult to raise a
It's
child one
Yeah.
at a time. But what people tend to forget is that the risk that are carried on with multiple pregnancies, and the highest risk is premature delivery.
Absolutely.
The time that the babies will spend in the intensive care unit if they are prematurely delivered, and the risk of cerebral palsy or any kind of brain insult they might have. So they might end up with having a child that is a burden on them for an entire life. And this is our mission. Our current mission now is to make people understand that twins are cute, but it is dangerous to be pregnant
Absolutely.
with twins. Triplets, definitely not. And I'm very happy that the government has forbidden transfer of 3 embryos to the uterus now.
I had no idea, but yeah, I mean, that is a good thing.
In Europe, it's 1.
Okay, because it is. I mean, with twins, even sort of, anytime you read on twins, the majority do end up in a premature delivery
And a
situation,
cesarean
they've got-
section.
yeah,
And
and
the
they're
risk
all
of a
in the
cesarean section and the
then the queue.
complications of
yeah.
cesarean section.
And so people would come and ask you,
Oh, yeah.
can I get some twins?
Yeah.
Two at the same time.
Yeah.
And it's just, I think one of the big ones I've got here in as a question is unexplained fertility. Again, a word that you hear thrown around a lot.
Yes, I know. This is something that is very difficult to handle because you run all kinds of tests,
Yeah.
whether it is on the woman, whether it's on the man, whether it's on genetic testing, immune testing, you name it, and we find nothing. And it is about 15 to 20% of the cases of fertility.
That's quite high.
Yeah.
Yeah.
IUI could be used sometimes in unexplained infertility with ovulation stimulation, stimulated inseminations. But I always think that the best option is to go to IVF with injecting the sperm inside the egg. Because sometimes what you have is an immune process around the egg, and the egg is pushing away the sperm, not allowing it to come in. So in some cases, I would recommend just to go ahead with injecting the sperm inside the egg. So IVF with intracytoplasmic sperm injection.
And so with something like unexplained infertility, does that run the same sort of time frame? When a couple has been trying for a year, they come in, do the test, everything comes out completely normal. And
yeah, you just have to go again. I would say it's case by case. It depends for how long you've been trying and what is the woman's age. I mean, you're 40 years old and you've been trying for a year and you've been told by 5 doctors that it's unexplained infertility. What am I going to tell her? Let's do an IUI and insemination? Definitely not.
No.
So you have to put everything in perspective. Yeah. The time, the regular unprotected intercourse, the ovulation, have we been ovulating? A lot of people, if you have noticed in the current world in which we live, people don't even have sex. I'm sorry to put it this way. She's busy, he's busy. Sometimes she's here, he's in Saudi, she's in, people don't have any more healthy sexual lives. Yeah. So even that's
definitely
part of
a topic
history.
for another episode. Yeah, no, it's true. Yeah.
So it's how you live your life impacts your fertility. We talked about it in the beginning, and I'm just bringing it back again to say that life has changed. Our grandmothers didn't have much infertility problems, did they? Because they got pregnant early, and they didn't have as much stress as we do have now.
That's true. So lives are busy and jobs are demanding and it's quite difficult and everyone's working till late and it's not easy. It's not easy at all. And of course, I think everybody wants to know in terms of fertility success rates. Are there procedures that offer a higher success rate than others? And is it something that is recommended? I mean, I guess, like you said, it's case by case. If you've got somebody over the age of whatever
Well,
it might
success
be.
rates depend also on the techniques. As I said, inseminations, low success rate because we're not doing very much. IVF has a very good success rate, but it depends also on the condition we are dealing with, whether it is, simple cases of infertility or it's complicated cases with male and female infertility cases. But the success rate is around 50 to 60% in women that are 35 years of age or below.
Okay.
But in our clinic,
In Bourn Hall, yeah.
we pride ourselves at following our patients until we have a delivery. And we count our success not by a positive pregnancy test, not by a positive fetal heart rate on an ultrasound, but by a take-home baby rate. And our take-home baby rate is 46%, all ages combined.
Oh, that's wonderful.
So I am
so
very
wonderful.
proud
No,
to be part of Bourn Hall Clinic.
Yeah.
We're doing a good job. We have a good team and a very, very good lab.
No, absolutely. I totally agree, and it's so nice that it's true. You're taking account babies that you've taken home from the hospital. Yeah,
That is the important thing. It's a healthy baby and a healthy mom.
Yeah, and a healthy pregnancy.
Absolutely.
Yeah, perfect. I absolutely love it. Dr. Diana.
Yes, my dear.
Thank you so much for coming on.
Thank you for having me. This was so nice chatting to you.
It's so lovely, but we're definitely going to have to do another one, I think, on egg freezing. So we'll stay tuned, everybody.
Okay.
I always, with each of the lovely, lovely special guests, I always ask them to give me a quote or a saying that they like, just to end the interview. Have you got one for us today?
Really? Sometimes all you have is hope. And that is often enough.
Absolutely.
It is written on our wall, and I will show you around the clinic
I would love to see it. I would love to
see how we work here.
Thank you so much for your time. Thank you for taking this.
Me.
Oh, it's my pleasure.
Really, really pleasure talking to you.
For sure. The pleasure is all mine. Thank you again.
Thank you.
Thanks a lot. Thank you for listening to They Say It Takes a Village. I hope you enjoyed today's episode. I look forward to bringing you another one next week. Don't forget, please subscribe, rate, and review so I can reach and help even more parents. And if you've got a topic that you'd like me to cover, please head over to my Instagram page, ittakesavillage.me, and drop me a line.